topic is fecal transplantation and inflammatory bowel disease would be presented by Dr. Waleed Al Shamrani, Assistant Professor of Medicine and Gastroenterology, King Saud bin Abdulaziz University, Consultant Gastroenterologist. Dr. Waleed, can you come please?
Dr. Waleed will speak about fecal microbiota.
Yes, and inflammatory bowel disease.
Clinical implication and therapeutic use. So we don't need medication, we need a stool to treat our patient.
Thank you for a nice introduction. So today I'll talk about fecal microbiota transplantation as an emerging treatment for GI disease and non-GI disease around the world. Okay. So before starting talking about fecal microbiota transplantation, just a quick talk about microbiome. And I know that yesterday we had a lecture about microbiome, so I will just go through this quickly. Just some fact that we all have more than 100 trillion bacteria plus fungi and viruses, and this is 10 times greater than the number of human cells in our body. There's 500 to 1,000 different species, and 60% of the stool volume is actually bacteria. The microbiome play an important role physiologically for the synthesis of vitamins and carbohydrate metabolism, as well as immune maturation and maintenance in both local and systemic, and inhibition of pathogenesis species, and communication with the enteric nervous system, or what we call brain-gut axis. I will go over some definition. Microbiome is a collection of different microbes and their function or genes found in an environmental habitat, while the term microbiota is the whole population of bacteria, viruses, and parasites and fungi colonized in intestinal tract. Dysbiosis is a perturbation in function and composition of microbiota that is driven by environmental and host-related factor. Studies, however, are biased toward Western societies. However, there are some studies coming from East Asia, and also they always ignore the other organism and concentrate only on bacteria, ignoring the viruses and fungi. And sampling is usually with the stool, ignoring the proximal intestinal mucosa, for example. There are main types of predominant bacteria phyla, and that is Bacteroidetes and Firmicutes, Acinetobacter, and Probacteria. So in this slide, most abundant bacteria family are shown in a circle where the size of the circle is proportional to the relative abundance of bacteria taxa and each growth stage. So in newborn, the intestinal microbiota initially colonized by enterobacteria, and even the route of delivery, vaginal delivery, the baby gain actually bacteria from the mother's vagina. So there has been studies about that normal vaginal delivery versus cesarean section. And the days after, anaerobe bacteria actually dominate the microbiome community. And then during the first month, bifidobacteria species predominate the gut, and then by introduction of solid food around 4 to 6 months, expansion of the bacteria with the clostridial species, and then by 2 to 3 years of age, microbiota composition is fully mature, consisted of Bacteroideaceae and Lancospraceae and Rominococcaceae, which then remain stable during the adult life. So the microbiome different from geographic area to another, ethnic group to another, depending on the diet, lifestyle, and environmental modified microbiome. These are the factors that affecting the stability and complexity of the gut microbiome in health and disease. So it's genetic, birth route, geographic, hygiene, stress, diet and nutrition, and drugs. So these factors can actually cause the microbial dysbiosis or can maintain a healthy microbe. So moving to fecal microbiota transplantation, it's a technique in which intestinal microbiota are transferred from healthy donor to the patient. And why we do it? Well, to restore a stable microbial community in the gut and to replace or inhibit pathogenic species. So does it work? We know without doubt that in C. difficile infection, it's very effective, and the cure rate is more than 90%. So the success of fecal microbiota transplantation in C. difficile has sparked interest for treating other conditions, including IBD. And the current state of knowledge indicates that the dysbiosis of the gut microbiota is implicated in several disorders that we will go through quickly. So it's not a new concept, actually. It has been there for a long time. You would know why I put this soup here. So in the 1st century, Ji Hong, a Chinese scientist, he used oral human fecal suspension he called yellow dragon soup for severe diarrhea, illness, and food poisoning. And then in 16th century, another Chinese, Lai Jensen, he used fermented fecal solution and dry feces to treat fever and severe diarrhea, vomiting, and constipation. While in 17th century veterinary medicine, they used fecal transplantation for horses with diarrhea. The modern use of fecal microbiota transplantation was in 1958 by Dr. Isman. He used enema to treat 4 patients with pseudomembranous colitis with dramatic response within 48 hours. So previous studies have suggested that intestinal microbiota alteration have been implicated in many gastrointestinal disease and even systemic illness, such as metabolic syndrome, neuropsychiatric condition, autoimmune disease, allergic disorder, and even tumor. So they start with donor selection and then donor screening, stool collection and preparation, and then patient preparation and stool administration. So for the donor selection, unrelated volunteer versus family or partner or friend, and then choosing donor must be healthy and avoid any donor with microbiota-associated disease like IBS, obesity, constipation, GI malignancy, or potentially transmittable disease. And donor must not have taken antibiotic recently, and in one facility, only 3% of candidates were acceptable when screened. So the donor selection screening before that is actually like any solid transplant organ. It's very strict criteria to select the donor. In regard for the patient preparation, patients should stop antibiotic 24 to 72 hours before and had a colonoscopy preparation the night before. The main route is retention enema, colonoscopy, nasodiodinal infusion, and also oral, which is capsule actually. And one study included 116 adult patients with recurrent C. difficile infection were enrolled between October 2014 to September 2018 with follow-up during December 2016. And patients were randomly assigned to fecal microbiota transplantation by capsule or by colonoscopy at 1:1 ratio. And prevention of recurrent C. difficile after a single treatment was achieved in 96.2 in capsule group and the colonoscopy group. So the conclusion was, among adults with recurrent C. difficile infection, fecal microbiota transplantation via oral capsule was not inferior to delivery by colonoscopy for prevention of recurrent infection over 12 months. So it is safe. The safety profile is good and generally tolerated. However, there are some theoretical risks like transmission of infection, transmission of microbiota-associated disease and complication during the procedure. And one review included 1,555 patients There was only 2 deaths related to aspiration pneumonia, 2 perforation during colonoscopy, and 1 related bacteremia 24 hours after, and exacerbated IBD in 6 cases. The most common side effect after the procedure is mainly diarrhea, followed by abdominal distension and bloating, abdominal pain and cramping and tenderness, and the rest are very rare. So you know that C. difficile treatment, it's in the guidelines for recurrent C. difficile infection, fecal microbiota transplantation, and usually with a good result, the diarrhea will subside in 48 to 96 hours. And in this study, you see that comparing to vancomycin, actually 93.8% were cured from recurrent C. difficile versus only 30.8% with the group of vancomycin. And it's really effective and cost-effective, even when you use colonoscopy for that, comparing to the medication. So we have a dysbiosis gut, and then the fecal microbiota transplantation will act either in indirect pathway, affecting bile acid metabolites or short-chain fatty acid metabolites, and this will affect immunomodulation and mechanical barrier function, or indirect way, acting against bacteria or direct transfer of metabolites from the donor, or also gaining the nutrients from the donor. So what about microbiome and IBD, and why we pay interest in microbiome and IBD? Well, IBD was thought to be an autoimmune disease before, but the current thinking is that it's actually an immune disease mediated by antigen, most likely a microbial antigen to which the immune system is reacting. So current therapy now are directed to dampening the autoimmune response, but it may be more sensible to just change what driving this immune reaction in the first place. So given the success in fecal microbiota transplantation in C. difficile associated diarrhea, it is possible that such an approach to be effective if IBD is driven by a disorder of microbiome. So there was small amount of observational case series data, but lately there have been many randomized control trial, although small, but they suggest that fecal microbiota transplantation may work in setting of ulcerative colitis. Crohn's disease, it's the same principle apply, but however, there is no randomized control trial. So in IBD pathogenesis, we know that environmental factor, gut microbiota, genetic predisposition, and host immune response, these are the main pathogenesis of IBD. However, current treatment only target one of them, ignoring the other, whereas diet, prebiotic, probiotic, or fecal microbiota transplantation and antibiotic may play an important role. And the studies actually showed link between microbiome and IBD. Just to, if you see here, the Crohn disease has less bacterial diversity and less cholesterol bacteria, and also less bacteroidesis and increase in enterobacteria. So these studies actually showed that there is a different in each disease in IBD associated with certain bacteria. As you see here in the right is patient with antibiotic, whereas in the left showcases without antibiotic, and increased disease activity associated with gaining certain bacteria, while the use of antibiotics does impact the microbiome and change the composition. So I have here with 13 minutes, I have my time, so sorry about that. So evidence for fecal microbiota transplantation in IBD. First randomized control trial was by Dr. Paul Muayyadi at McMaster University, and we used weekly 50 ml of fecal microbiota transplantation for 6 weeks versus placebo in 70 patients divided, And the remission rate was 24% in fecal microbiota group versus only 5% in placebo group. An increased response with fecal microbiota in immunosuppression, 46%, while only 15% without immunosuppression. So although this study is not really impressive, the result is not impressive, but it was the first randomized trial to demonstrate that fecal microbiota transplantation can be effective in ulcerative colitis. This meta-analysis came from China very recently, included many randomized control trial about fecal microbiota transplantation and UC, and in specific they choose only 8 studies at the end, and they observed that the patient that received fecal microbiota transplantation had more apparent clinical response rate of 59.23% compared to the placebo group, which is 39.13%, with a significantly statistical difference. So they also observed that the efficacy of colonoscopy was the same as enema, and unrelated donor group had higher clinical remission of 36% with
1 minute, ya Waleed. We are late.
So any ethical issue? Well, we don't know what exactly being given to the patient, first of all, and there is not enough evidence to suggest that fecal microbiota transplantation can actually be used in clinical practice. So at the moment is all should be used for clinical study. What about Crohn's disease? In Crohn's disease, there have been only observational data which showed about 2/3 of people went into remission. However, case series are typically small and overestimate the success. There have been small cohort study performed with mixed results, and the meta-analysis about these small studies showed 52% remission rate among 71 Crohn's disease. So the only study reporting endoscopic outcome in Crohn's disease showed an endoscopic remission at 8 weeks, but no actually endoscopic healing. What about IBS? Before there was a small study showed 70% improvement in bloating, constipation, and diarrhea in 13 IBS patients, but most recently there was a randomized control trial investigating the effect, and a patient received 1 donor fecal microbiota transplantation infusion with fresh frozen feces, and or the other group autologous.
Waleed, can we conclude? We are very late. Can we conclude at the end? We are very late, 5 minutes.
Yeah, but I didn't have my full time. That's
Try to.
sure. Okay. So this study showed that 65% of patients they had decrease in IBS severity score versus 43% of those who received autologous fecal microbiota transplantation. However, after 12 months, the difference between two groups was less pronounced. So we need more research to answer which IBS patient should be selected for fecal microbiota transplantation and which donor microbiota is effective. So what about extraintestinal disease? Well, as we said, if you search, you will find a lot of study now. It's becoming a trend about fecal microbiota transplantation. I will talk just briefly about some of them. Fecal microbiota transplantation and hepatic encephalopathy. Patient with cirrhosis, we know that he has dysbiosis of the gut microbiota, and this will lead to pro-inflammatory environment in the gut with increased ammonia. This hyperammonia is alter the gut microbiota and will cause neuronal dysfunction and hepatic encephalopathy. There has specific bacteria like Lachnopspraceae and Romainococcaceae and Clostridialis have been associated with protective properties. So in the study, they choose those donors who have actually these bacteria abundant, and there has been one randomized controlled trial with 10 participants with liver cirrhosis and recurrent hepatic encephalopathy were treated with a single fecal microbiota transplantation versus and also antibiotic and the conventional therapy lactulose and rifaximin, where the other group of 10 received solely the standard care of treatment. So The different, they were all, the microbiome at the day 0 were the same between two groups, but after antibiotic, we see here that the composition is different in microbiome, and further, day 12, which is day 7 post-fecal microbiota transplantation, you see the difference. And there has been no serious side effect, only 2 versus 8. And surprisingly, there is no hepatic encephalopathy episode on those who received fecal microbiota transplantation. Also, there is evidence in graft versus host disease with 2 small case series. And evidence in multi-drug resistant organism as well. Also in the metabolic disease, the microbiota is closely linked to a series of metabolic disease like obesity or diabetes mellitus. And there have been 2 small studies showed that increase in insulin sensitivity either in peripheral or hepatic.
Waleed, please conclude. We are late even in your time.
Sure, okay. So I have to stop here. I didn't have my full time, but to organize our conference. So I just want you to take a home message from this subject, that we are still in the stone age of fecal microbiota transplantation, and fecal microbiota transplantation is proven to be well established in C. difficile infection. And if you go to clinical trial, that government website, there is more than 200 studies about fecal microbiota transplantation. And that means that this approach has found its way to the scientific community. However, additional high-quality data are urgently needed for further establish the efficacy and to define the protocol in each separate indication, because there is no specific protocol. So although fecal microbiota transplantation appears to be safe and easy to perform, it should be used with caution because of long-term effects are still unknown or organized.
Thank you. Thank you.
Thank you, Dr. Waleed, for this excellent
I
presentation.
didn't have my full time.
No problem.